So a very good evening. I am Valerie Mendes, General Manager Marketing.
Yeah.
And on behalf of Aristo Pharmaceuticals, I extend a warm welcome to all distinguished delegates and sincerely thank each one of you for taking out your time and joining this esteemed scientific forum, the Bridge Summit, under the auspices of the Indo-Global Cardio-Diabetes Academy,
Yeah.
supported by Aristo and from the makers of Empatrol. Your presence here truly is a testament of your commitment for advancing knowledge. At Aristo, our endeavor is to disseminate some of the latest and high impact scientific updates so as to enhance your in-clinic efficiency and support continuous advancement of knowledge and skills. Aristo has been in the service of the healing hands since the year 1971, completing glorious 55 years, relentlessly making quality healthcare accessible to all. With its state-of-the-art WHO GMP certified manufacturing facilities, today we have carved our footprint across 25 countries worldwide. And on the prescription front, compared to all other companies, Aristo ranks as the top fifth company in terms of prescription, and it owns the prestigious distinction of being the number one company in the covered market in the state of Bihar. So I think we have been able to achieve this feat with your trust and with your support. So a big round of applause. We have gathered here today, this evening, for one of the finest scientific forum, the Bridge Summit. As the name indicates, it connects scientific minds, it encourages evidence-based discussions, and it's a forum for exchange of clinical insights. I'm sure you will agree with me that diabetes management today has a whole new understanding and a whole approach of a holistic management, which involves the cardio, renal, and the metabolic management. So, the topic for the day in the Bridge Summit is managing CKM syndrome in type 2 diabetes. So, it is said that there is a famous saying that best teachers make a difference in the classroom. So, to further strengthen the understanding of the subject, to provide an in-depth clinical insight, today we have with us none other than the global icon. He is the pioneer of inventing the SGLT2 inhibitors. He has transformed the understanding, the pathophysiology, and the management of diabetes. In fact, influencing a lot of clinical guidelines and also created a difference in millions of lives. We have with us today none other than the world renowned endocrinologist, a legend in himself, and we are so fortunate to have him here. Let's welcome Professor Dr. Ralph DiFranzo. I think let's give him a standing ovation, a big round of applause. Our esteemed international speaker, and now I request Dr. Santosh Kumar sir, Dr. Satish Kumar, and Dr. Anant Kumar to kindly felicitate sir.
Ah.
Dr. Satish Kumar, Dr. Anant Kumar, is he there?
Thank you. Yeah, we'll give. Yeah.
Sir, I request you to kindly have a seat over there.
Okay.
Yeah. And now I would take the privilege to introduce our panelists who are known for their expertise in their respective domain. And we have with us one of the most renowned, very well known, our moderator, and he's also a panelist, one of the renowned endocrinologists of India, not only Bihar, Dr. Santosh Kumar Singh. President, Endocrine Society of India, Bihar chapter, President of RSSDI Bihar chapter 2018, and President of the Bihar Diabetes Federation. We welcome you, sir. A big round of applause. I request Dr. Sehwal Gua to kindly felicitate, sir. Sir, kindly take your seat. We now have with us our panelist, Professor Dr. Ashok Kumar, an esteemed interventional cardiologist with over 15 plus years of experience in advanced cardiovascular care, Director of the Cardiac Sciences HDNA Arogyam Hospital, Patna, Professor of Cardiology PMCH. I think Dr. Ashok Kumar is yet to arrive. So by the time he comes, we will do the felicitation a bit later. In the next time, by the next time, we have our next panelist. He is a leading consultant nephrologist, Dr. Shashi Kumar. He is the director and head of nephrosciences department at the Paras HMRI Hospital. Let's welcome Dr. Shashi Kumar. And to felicitate him, I call on Dr. Abhishek Pratap Singh. So please have a seat. So let's clap for our panelist and Professor DiFranzo. But yes, along with our experts present here, I would share with you that we are going live across 3 centers in India. That is Chandigarh, Ahmedabad and Mumbai. So at Chandigarh, we have our regional moderator, Dr. B.S. Bhatia, senior consultant physician cum diabetologist and cardiologist, practicing at the Bhatia Heart and Diabetes Center, Chandigarh. Let's welcome him. I request the camera to highlight Dr. at Chandigarh, Dr. Bhatia. Okay, we have Dr. Bhatia there, the regional coordinator at Chandigarh. Thank you. Then at Mumbai, we have the very well-known Dr. Sanjay Godbole. He is professor and head of Department of Medicine, NY Tasgaonkar Medical College, Mumbai. Dr. Sanjay Godbole, Mumbai. And then at Ahmedabad, we have the regional moderator, Dr. Hitesh Patel, a leading physician from Ahmedabad. Great. So I think a big round of applause to all the regional moderators as well. A teacher plants the seeds of knowledge, sprinkles them with love, and nurtures their growth. So, with these beautiful lines, I now invite our Professor Dr. DiFronzo, Dr. Santosh Kumar Singh, and our nephrologist, Dr. Shashi Kumar, to kindly come and inaugurate the lamp and officially unveil the meeting.
Yes. Yeah. Whoops, come back. You go first. I go first. Oh, very windy. Yeah. No, there we go. Sort of. No, no.
So I now officially invite Dr. Santosh Kumar Singh, who would moderate the session for today. Thank you.
Thank you, Valerie, for this opportunity. Uh, Sincere thanks to Aristo people. We are blessed today to have the legend. It's a dream comes true to have Professor Ralph DiFronzo before us. I was set to introduce him. Uh, and what we have learned is his introduction. And it was in 1981, he was the person who gave the idea of the triumvirate. Everybody of us correlate with the hepatic insulin resistance, the muscle insulin resistance, the beta cell dysfunction which we have. And from there, after a decade, he has coined the ominous octet, and everybody of us is well aware of that concept of ominous octet. It doesn't end over there. You have a display of Deputy Director, Texas Diabetes Institute. And we need to remember this, because this is a single center and which coined the EDIC study. And I remember one of his sir's deliberations, he said that if somebody was not willing to go for that concept of triple therapy, I didn't used to treat him. So that was his conviction. So he started with the metformin, pioglitazone, and exenatide at that time, triple therapy, when all of us were following the AD algorithm of metformin, sulfonylurea, and insulin. At that time, he had this concept of triple therapy, pathophysiology driven treatment, which was evident from the ominous octet. Then it followed the follow-up study almost in 2015 was EDIC, 2021 is the follow-up study, and you will be astonished that 10 years later, there was an extension of that study where he had seen about the MAFLD status, reduction in liver fat, and the fibrosis thereof, and reduction of CIMT. With this triple combination therapy vis-a-vis the standard stepwise therapy which we have. It is not only the part of diabetes itself. He was introduced as endocrinologist, and you will be astonished, he is one of the, again, pioneers of the catalyst trial. And you might be knowing that catalyst trial is linked with hypercortisolism in type 2 diabetes. And the second part dealt with the treatment of that, including mifepristone, which acts as a cortisol antagonist. So this is the scenario which you can just imagine whom we are having before us. So it's my pleasure to have Dr. Ralph DeFonso, Professor Ralph DeFonso, for this bridge meet. And if you remember, go by the acronyms, bridge is beyond the routine. And who else than Dr. Ralph DeFonso talking about beyond the routine? It's definitely a separate thing, and we'll be talking about the evolving empagliflozin use in this bridge summit. So it's my pleasure to invite Professor Ralph DeFonso for his talk on CKM, and it is through his lens we'll be talking today about CKM. Sir.
Okay, thank you. Okay, it's a great pleasure to be here. I actually didn't bring the rainstorm. I got here before the rainstorm. So you heard about triple therapy. This is the EDIC study. And this actually, EDIC study is the first time the American Diabetes Association has ever recommended combination therapy. So the original EDIC study was metformin, and I brought metformin to the United States in 1995. An old-time GLP-1, exenatide, which is really an old-time, and pioglitazone. And that triple therapy now actually has been modified. And so instead of using metformin, we use an SGLT2 inhibitor as part of the triple therapy. So tonight, I'm going to focus on the SGLT2 inhibitor class of drugs, and specifically, I'm going to talk about empagliflozin. But you need to remember that if you're going to take care of diabetic patients, and we'll talk about the ominous octet, we have many pathophysiologic disturbances, so you're going to require multiple drugs to correct these multiple pathophysiologic disturbances. So where does the story start? The story starts with fluorescein. And many of you here may never have heard of fluorescein. But when I was a renal fellow, I was trained as a micropuncturist, and I was particularly interested in glucose and phosphate and sodium transport in the kidney. And I knew that insulin, and we were the first people to show that insulin markedly increased sodium and glucose transport in the proximal tubule. And I wanted to study what would happen if you blocked the ability of insulin to increase sodium and glucose transport. And I knew about this drug called fluorescein. And fluorescein comes from the bark of the apple trees when the apple trees bloom in the spring. And fluorescein is a very, very potent inhibitor of glucose reabsorption in the proximal tubule. And in fact, when I was a renal fellow, it dawned on me that this could be a very, very effective treatment for people with type 2 diabetes. And when I moved on to do my endocrine fellowship, I actually worked with this drug, and this led to what we're going to talk about tonight, which is empagliflozin. And all of these studies were published in the late 1980s, early 1990s. And what we showed, starting off in animal models, and we looked at a number of animal models of diabetes, that if you used fluorescein to block glucose reabsorption in the proximal tubule, you simply urinated out the glucose in the urine, and the blood sugar level came down. And when the blood sugar level came down, what we noted was there was a major improvement in insulin sensitivity. And at the molecular level, the reversal of what we termed glucotoxicity was explained by two factors: an improvement in the insulin signaling system and an improvement in the glucose transport system. And we also showed that as the glucose level came down, there was a major improvement in insulin secretion. And we coined the word glucotoxicity. High glucose of course, is the way we diagnose diabetes. High glucose is what causes the eye, the kidney, and the nerve damage. But high glucose is also contributing to the pathophysiology. So high glucose causes insulin resistance, causes beta cell failure. You simply pee the glucose out in the urine, blood sugar level comes down, you improve insulin sensitivity, you improve beta cell function. It was such a simple concept, no one thought about it, okay? And as I said, we did the original studies with dapagliflozin. And I'm going to show you the original studies in a few moments. So all of these beautiful studies we did in rodents, of course, we wanted to know, look, what we learned, was it applicable to humans? And the very first study was done with dapagliflozin. And in fact, the entire drug development of dapagliflozin with Bristol Myers Squibb was done and then AstraZeneca was done by myself. So you'll see the results are so profound, you don't have to study large numbers of people. So in this study, we randomized 12 people to dapagliflozin, 6 people to placebo. Very typical diabetics everywhere in the world now are obese. It's very difficult to find lean type 2 diabetics, BMI 34, and A1C about 8.6. So what did we show? If you look at the fasting glucose concentration, it fell by about 30 milligram per deciliter. During the OGTT, the mean glucose fell by about 70 milligram per deciliter, which means the increment in glucose above baseline fell by about 40 milligram per deciliter. So dapagliflozin in this study was very effective in lowering the fasting glucose and in lowering the postprandial glucose. And then during the OGTT, we got a measure of insulin secretion, the increment in C-peptide by the increment in glucose, and you can see we doubled the amount of insulin which is being secreted. And many years ago, we developed a technique for measuring insulin sensitivity called the insulin clamp technique. We're going to infuse insulin, and then using radiolabeled glucose, we can quantitate the amount of glucose that's taken up by all the tissues in the body. And you can see this 35% improvement in insulin sensitivity. And then to the far right, the gold standard for beta cell function is to take how much insulin is secreted, factored by how insulin resistant you are. And you can see we double beta cell function. So in this very early, very small study published in the Journal of Clinical Investigation, we showed that a drug that would just increase glucose excretion in the urine, decrease the blood sugar level, by reversing glucotoxicity, markedly improved insulin sensitivity and beta cell function. So obviously, this is going to be a good drug for the treatment of type 2 diabetes. And then we went on, and I also was the chief consultant for Boehringer Ingelheim, and repeated these studies with empagliflozin. And you can see at baseline, this is the amount of insulin, the increment in C-peptide during the OGTT. Within 2 days, a major improvement in insulin secretion, which persisted up to 14 days, just as what we showed for dapagliflozin. And this is now with the insulin clamp. The rates of insulin-mediated glucose disposal, there should be little asterisks here, also improved by about 35%. And then this disposition index, which is the gold standard for beta cell function, also doubled. So what we showed is that empagliflozin did exactly the same thing as dapagliflozin in terms of improving insulin sensitivity in beta cell function. So many of you have heard of the ominous octet. And in 1987, I was awarded the Young Investigator Award at the American Diabetes Association. And I simply called it the triumvirate. So what is the triumvirate? The triumvirate is insulin resistance in the liver, insulin resistance in the muscle, and beta cell failure. So all of us, last night, we went to sleep. And we woke up this morning. So why does that happen? You go to sleep, your fasting glucose is 80. You haven't eaten anything throughout the sleeping hours. You wake up this morning and your fasting glucose is still 80 milligram per deciliter, but you haven't eaten anything. So how do you keep your glucose at 80 milligram per deciliter? Throughout the sleeping hours, your liver puts glucose into the systemic circulation at a constant rate, and it clamps your glucose at about 80, okay? What goes wrong in the diabetic? The diabetic liver is severely resistant to insulin. So throughout the sleeping hours, the liver overproduces glucose, and that's the cause of fasting hyperglycemia. So obviously, we're going to need drugs that work on the liver to shut down hepatic glucose production. The diabetic wakes up in the morning, and they're going to have their breakfast, then eventually their lunch and their dinner. That carbohydrate, the glucose that's in the meal, needs to be taken up in the muscle. But in the person who has type 2 diabetes, the muscle is resistant to insulin. We get postprandial hyperglycemia. And then this insulin resistance is all aggravated by the beta cell failure, which is genetically determined. So this was the triumvirate. In 2008, I gave the Banting Lecture, which is the Lifetime Achievement Scientific Award by the ADA, and I called it From the Triumvirate to the Ominous Octet, a new paradigm for the treatment of type 2 diabetes. So we have 5 other players that we have to account for. So in the upper right is the fat cell. The fat cell initially is your friend. You take in excess calories, and you put those calories and you store them in the form of triglycerides in the fat cell. They can't hurt you there. But if you keep taking in excess calories, as the fat cells expand, they become very resistant to insulin. And now you break down the triglycerides, you release FFA into the bloodstream. Well, elevated FFA cause insulin resistance in the muscle, insulin resistance in the liver, and cause progressive beta cell failure. So the fat cell, who's initially your friend, now turns against you. We also know that the gut is a giant endocrine organ. And when you eat a meal, you release 2 incretin hormones, GLP-1 and GIP. And those 2 incretin hormones account for about 70% of the insulin that you secrete during a meal. So what goes wrong in the incretin axis? Is it you don't make enough GLP-1 or GIP, or your beta cells don't respond to GLP-1 and GIP? It's the later. You make enough GLP-1 and GIP, but your beta cells are very, very resistant to that GLP-1 and GIP, and this is a major acquired cause of the beta cell failure. We also know that the alpha cell plays a very important role in the pathophysiology of type 2 diabetes. So Dr. Roger Unger showed many years ago that your alpha cells hypersecrete glucagon, and those elevated glucagon levels are responsible in part for driving hepatic glucose throughout the sleeping hours and contribute to the fasting hyperglycemia. And we subsequently went on to show for the first time that the kidney played a very critical role in the development of type 2 diabetes. So there's a particular transporter in the kidney, and we'll come back to this, called the SGLT2 transporter. And we showed that in diabetics in whom we did kidney biopsies, there was upregulation of this SGLT2 transporter. The S is for sodium, GL is for glucose, T is transporter. And because that transporter is upregulated, even though the diabetic filters more glucose, it doesn't appear in the urine. It's all reabsorbed in the proximal tubule. And so we're going to need drugs that block glucose transport in the kidney. And we're going to speak a lot about these SGLT2 inhibitors and empagliflozin tonight. And then lastly, the brain, number 8 of the ominous octet, plays a very important role as well. So how does the brain contribute to diabetes? Well, what's driving the epidemic of diabetes today is the epidemic of obesity. And in the hedonic areas of the brain, the amygdala, the putamen, the prefrontal cortex, there is marked changes in the decrease in the gray matter area and disruption of the neural circuitry. So when you look at food, food looks especially good. Food in obesity is an addiction, okay? So overweight, obese people actually are addicted to food. It's no different from alcohol addiction or opiate or drug addiction. So these people overeat. When you become obese, that makes all the tissues in your body very, very insulin resistant. So obviously, if we have 8 problems to deal with, one drug can't correct 8 problems. We're going to need to use drugs in combination, and we should use drugs that correct multiple defects. And we've also learned that diabetes is a whole body disease. It's just not a matter of hyperglycemia, which causes eye, kidney, and nerve damage. It is a disease that affects your heart, accelerated atherosclerosis, heart failure. It affects your kidneys, kidney failure. It affects your liver. This is MASH and MASL, okay? So when you use drugs, you need drugs that are going to correct multiple pathophysiologic disturbances and correct multiple organ disturbances in the body, okay? So tonight we're going to focus on the kidney, but you need to understand that there are multiple tissues that are involved. So how do the SGLT2 inhibitors work? Their primary mechanism of action is on the kidney. Actually, SGLT2 inhibitors are only present in the kidney. So now we showed in the old days with fluorescein, and now with empagliflozin or dapagliflozin, I'm going to block glucose reabsorption in the kidney. The glucose comes out in the urine. Blood glucose concentration comes down. I get rid of the glucotoxicity in the muscle, and as I showed you, I improve insulin sensitivity. I get rid of the glucotoxicity at the level of the beta cell. I improve insulin secretion. So I'm going to talk a little bit more in depth about the renal mechanisms by which the SGLT2 inhibitors work. So every day of our life, the glomerular filtration rate is about 180 liters per day. Fasting glucose is 100. So we filter 180 grams of glucose every day. How much glucose ends up in the urine? And you and I, none. How does this happen? So in the early proximal tubule, there's the SGLT2 inhibitor, and this takes back 90% of the filtered glucose. If it does its job, the SGLT2 inhibitor, which is a little bit downstream, takes back the remaining 10%, and no glucose appears in the urine. And so what we did is we did kidney biopsies in people with type 2 diabetes. And what we showed is that there's a marked upregulation of the SGLT2 inhibitor. So that, of course, now forms the basis of which we use the SGLT2 inhibitors. I block that transporter, and you're simply going to pee the glucose out in the urine. Blood glucose comes down. I reverse the glucotoxicity. So this is a study. It's published in Diabetes Care over a decade ago. And this has to do with the concept of the renal threshold. So you learned all about this when you were a medical student, and I'm sure you forgot everything about it once you graduated from medical school. So I'm going to take you back to your renal physiology days. So I'm going to plot the fasting glucose concentration here on the x-axis against urinary glucose excretion on the y-axis. And now I'm going to infuse glucose, and I'm going to raise your glucose from 80 to 90 up to 180. How much glucose appears in the urine? None. This should be 0. And then when I get to a glucose of 180, all of the glucose which is filtered appears in the urine, and this is a normal glucose tolerant individual with an A1C of 5. Now, what happens as you become diabetic? You can see this diabetic with an A1C of 5, that threshold is already increased by about 20 to 30 milligram per deciliter. So you can already see in the earliest stage of diabetes, remember A1C 6.5, that's when we make the diagnosis of diabetes, okay? There's already an increase in the threshold. And very paradoxically, as the A1C goes up, the worse your glucose control, the higher the threshold. A1C 8.5, even higher threshold. A1C 9.5, you can see the threshold now is 260. So the diabetic kidney, instead of dumping the glucose, which is what we would like it to do, is now reprogrammed. Higher the glucose, the more I'm going to hang on to the glucose. This is very, very paradoxical, and it has everything to do with this upregulation of SGLT2. And that's why these SGLT2 inhibitor drugs are actually so effective. Okay, so now I'm going to now show you how the SGLT2 inhibitors work. So I have already shown you this. As I raise the glucose from 100 to 180, no glucose in the urine. Once you get to this threshold, you dump all of the glucose in the urine. Schematically, I've just shown a diabetic patient with this elevated threshold. Now I'm going to treat them with empagliflozin. And we've done this study with canagliflozin and dapagliflozin. You get exactly the same result. Do I lower the threshold to 180? No. Do I lower it to 100? No. How low do I lower it? I lower the threshold to 40. Now, what does that mean? That means if you have normal kidney function, there is no such thing as a non-responder. Why? Because I lowered your glucose way below your fasting glucose, which means for sure you're going to respond. But now, if you think about this, you can ask, why don't all these patients get hypoglycemic? Well, in the process of doing these studies, what we showed, as soon as your glucose gets down to 80 or 90, okay, a signal goes from the kidney through the renal nerves to the liver, and your liver makes an amount of glucose which is exactly equal to the amount of glucose that's coming out in the urine. It's an incredible system. So this whole new physiology was never realized. None of you ever studied this in medical school, and in fact, we only found this out in the last 5 to 10 years. This system is so finely tuned that even though I lower that threshold to 40, you will never, ever see hypoglycemia. Unless, of course, you're using the drug with insulin or sulfonylurea. But in the absence of insulin or sulfonylurea, hypoglycemia does not occur. Now, as I said, and these data now are published in a recent article, and the conclusion is, if you're a cardiologist, you can use this drug and never have to worry about hypoglycemia. This class of drugs should be the friend of the cardiologist. If you're a nephrologist, this should be your drug. You do not have to worry about hypoglycemia. And if you're an endocrinologist, this should also be your drug. But more importantly, for all of you here, primary care physicians, internal medicine, this should be your drug, okay? You cannot cause hypoglycemia unless you're using it with insulin or sulfonylurea. And as I'm going to show you, there are lots of benefits in addition to lowering glucose in terms of cardioprotection and renal protection. So from the clinical standpoint, where do these SGLT2 inhibitors sort of fit in the treatment algorithm? So I'm going to show you a series of slides. They're pretty much all the same. So I'm going to plot here the decrement in A1C. And in these studies, the starting A1C is about 8. So these are people who are going to be treated just with diet and exercise. And with empagliflozin, there are 2 doses, 10 and 25 milligrams. They're the light orange and the dark orange, and the yellow is in placebo. And you can see, starting with an A1C of 7.9, I dropped the A1C by about 0.8 to 1. If you're on metformin and I add the empagliflozin, same effect. If you are on metformin SU, same benefit. Pioglitazone, which is one of my favorite drugs, I have the same effect. So across the board, it really doesn't make any difference whether you're being treated with diet and exercise or any other medication. You can add the SGLT2 inhibitor and you're going to get the exact same additive benefit. Why? Because these drugs work by the kidney, a totally different mechanism than all the other drugs. Now, what about fasting glucose? You can see here with the 10 and 25 milligrams, it drops by about 1.5 millimolar. That's about 30 to 40 milligram per deciliter. And I showed you earlier, you get about a 40 milligram per deciliter decline in the postprandial glucose. Now, what about body weight? Because you're losing glucose in the urine, that's calories. And at the end of 6 months, you can expect about a 2.5 to 3 kilogram decrease in body weight. So these are drug-naive patients. You're on metformin, metformin SU, or insulin. Insulin makes you gain weight. When you add the SGLT2 inhibitor, you actually lose weight. You don't get all of the weight loss that you see in monotherapy or metformin sulfonylurea, but there's no weight gain. and modest weight loss. Now, what about blood pressure? Because you block not only glucose, but sodium reabsorption, you go into some mild negative salt and water balance, okay? And not surprisingly, if you look at systolic blood pressure, you get about 3 to 4 millimeter decline in systolic and about a 1 millimeter decline in diastolic. And remember that most of our diabetic patients have hypertension. And these are people who have normotension. The higher the starting blood pressure, the greater the drop. So if your starting blood pressure was, instead of 125 over 80, let's say it was 140, 150, the systolic blood pressure would drop about 6, 7, 8 millimeters of mercury. So this is, again, a very beneficial effect. Now, how does empagliflozin stack up against other anti-diabetic agents? So we know that the higher the starting A1C for all drugs, the greater the drop is in the A1C. So this is a study that I was in charge of with Boehringer Ingelheim. And what you can see here now on the x-axis is the A1C, going from 6 up to 11. And the higher the A1C, the greater the drop is in the A1C. And you can see sitagliptin and glimepiride, the sulfonylurea. Basically, these curves are parallel. Now, what about empagliflozin? For any given A1C, empagliflozin always gives you a greater drop in the A1C. So in terms of efficacy, the empagliflozin is clearly more efficacious than the sitagliptin or the glimepiride. And this is a study that I also directed for Boehringer Ingelheim, looking at combination therapy with empagliflozin and linagliptin. So there's a placebo run-in period, and then the patients are going to be randomized to one of 5 categories. One group is going to get linagliptin, a DPP-4 inhibitor. One group is going to get the low dose, and the second group, the high dose empagliflozin. And then the other 2 groups are going to get empagliflozin plus linagliptin. So what happens? A1C starting about 8. You can see again in this very large study, linagliptin, the DPP-4 inhibitor, is not as effective as the SGLT2 inhibitor. If you look at empagliflozin, whether it's 10 or 25, you get that about 1% drop in the A1C, clearly better than the linagliptin. But what's important is when you put the linagliptin with the empagliflozin, whether it's the high or low dose EMPA, you get, and you never get a completely additive effect, but you get an additive effect. So this is a good combination that you can use in your practice. And I'm a big believer in using multiple drugs right from the beginning, not the stepwise approach. And this is the same study, just shows you the time course. So the linagliptin is in green, and the empagliflozin in orange, and the combination is in yellow. And you can see a fairly rapid decline in the A1C within the first 4 to 8 weeks. And then upwards of 2 years, you see this benefit. In addition, there's something that's very important. If you start with monotherapy, at the end of the first year, these drugs tend to fail, particularly the SGLT, the DPP-4 inhibitors. But when you use combination drugs together, you get a more prolonged maintenance of the drop in the A1C. Now, what about body weight? The DPP-4 inhibitor, linagliptin, is weight neutral. What's driving the weight loss, whether you use empagliflozin alone or the combination of the two, is the SGLT2 inhibitor, okay? Now, you can also use triple therapy. So this is a study in people who have failed on metformin, and then we're going to add a combination of either empagliflozin with linagliptin to the metformin, okay? So basically, these people are on metformin, they've failed, and now I'm going to add a dual combination of EMPA and linagliptin, okay? So here's when I add the empagliflozin alone to the people who have failed on metformin. This is when I add the linagliptin in the people who have failed. And here now I add the combination of empa and lina, and this is Trijardi. And in fact, this study was done here in India. So you can use triple combination therapy. And a number of companies I know make this triple combination pill, including the company that we're speaking for today. So I'm a big advocate of triple combination from the beginning. I don't like monotherapy, okay? Why? Because after a year, you start to see failure. Dual combination therapy, in my opinion, is much better than monotherapy. And the triple combination, I actually favor. So here you can combine metformin, empagliflozin, linagliptin, and metformin. This is going to get the A1C down, and it's going to improve patient compliance. They don't have to take 3 pills, and you don't have to be seeing the patient so frequently to upregulate and add the next class of medication. Now, as I told you, type 2 diabetes is a cardiovascular disease. It affects the heart, okay? So what have we learned about the SGLT2 inhibitors? So the very first cardiovascular outcome study was done with empagliflozin, and I'm going to show you that in a second. So what do the SGLT2 inhibitors do? They correct that novel pathophysiologic defect. The kidney is hyperreabsorbing glucose along with sodium. I'm going to block that. You put the glucose out in the urine, and as the glucose level comes down, I improve beta cell function, I improve insulin sensitivity, I get a nice drop in the A1C. Now, because you're losing calories in the urine, the yellow little block to the left, you're going to lose weight about 2.5 to 3 kilos. And because the drug works on the kidney, different from all other drugs, you can use this drug in combination with any of the other drugs. You waste a little bit of sodium in the urine, you get a nice drop in blood pressure, no hypoglycemia. Now, because I'm correcting some cardiovascular risk factors, in addition to improving glycemic control, you may expect some benefit in terms of the cardiovascular system. So this is the EMPA-REG outcome study. It was the lead article in the New England Journal of Medicine about a decade ago by Dr. Zinman. And when this was presented at the American Diabetes Association, there were about 15,000 people in the audience. And as these data went up, you could everybody goes, woo! And 15,000 people stood up and clapped. So this is an incredible study. Now, to get into the EMPA-REG outcome study, you had to have a previous cardiovascular event. Could be an MI, stroke, some kind of cardiovascular event. In order to get a drug approved in the United States by the FDA for a cardiovascular indication, the FDA requires that you show benefit on the MACE outcome. MACE stands for Major Adverse Cardiovascular Events. So here is the MACE outcome to the left. Hazard ratio is 0.86. This is a Kaplan-Meier plot to the MACE outcome. And that is highly statistically significant, big study, 7,000 people. So hazard ratio 0.86 says there's a 14% relative risk reduction in having either non-fatal MI, non-fatal stroke, or cardiovascular death. But what I want to emphasize, if you look down here in the lower left, this separation occurs very quickly. Within the first 2 to 3 months, you already got a statistically significant benefit, okay? What caught everybody here was the effect of empagliflozin on cardiovascular death. Hazard ratio is 0.62. There was a 38% decrease in the likelihood of your dying. That's incredible, okay? That's a huge, we never seen anything like this before. And then to the far right, this is heart failure, hospitalization for heart failure, hazard ratio is 0.65. So we're seeing like a 35 to 40% relative risk reduction in cardiovascular mortality and also heart failure. So this was the very first SGLT study showing cardiovascular benefit. We eventually saw the same thing with the other SGLT2 inhibitors, but this was the very first one showing this dramatic benefit. Now, we also know that there was a follow-up of the EMPA outcome study called the EMPA Reduced, and this was a heart failure study. So to get into this study, you had to have a low ejection fraction and you had to be symptomatic. And again, you see these curves separate very quickly within the first month. And the hazard ratio in this EMPA Reduced study is 0.75, meaning there's a 25% decrease in hospitalization for heart failure. So now in the United States, if you're diagnosed with heart failure, you started on the drug while you're in the hospital. We don't send you home to the primary care physician with the prescription to be filled. You get the drug in the hospital and the prescription is filled in the hospital, okay? Now, in addition to heart failure with reduced ejection fraction, which is in large part an atherosclerotic ischemic disease, people with type 2 diabetes much more commonly get heart failure with preserved ejection fraction. This is the result of hypertension, fat deposition in the myocardium, okay? This is called HFpEF, heart failure with preserved ejection fraction. So here now is the empagliflozin preserved ejection fraction study. And again, hazard ratio is 0.79. And again, you can see that these curves separate very, very early within the first year. So this drug, empagliflozin, is very good in terms of protection against heart attacks. It's very good giving you protection against heart failure, both with reduced ejection fraction and preserved ejection fraction. What we didn't see with empagliflozin, and we've not seen this with any of the SGLT2 inhibitors, is no benefit on stroke. And this still remains unexplained. Why? Because these drugs lower your blood pressure. And I think everybody in this audience knows that hypertension is a major risk factor for stroke, okay? Why we don't see it, it doesn't make any difference whether it's dapagliflozin, canagliflozin, ertugliflozin, all the other gliflozins. We've never seen a decrease in stroke, unexplained. But we also always see cardiovascular protection and protection from heart failure. Now, one of the other things that was noted in the EMPA Reduced trial was that there was a benefit on preserving glomerular filtration rate. So I've plotted for you here the change from baseline in the GFR as a function of time. The placebo group is in yellow. You can see GFR following linearly. In the group treated with empagliflozin, there's an initial small decline in the eGFR. I'm going to explain to you later why this happens. But then on a long-term basis, you see, in fact, these curves cross, and the orange curve, which is the empagliflozin, you get better preservation of glomerular filtration rate than compared to the placebo. I'm going to explain to you why this happens. And then actually just a couple of months ago at the American Society of Nephrology meeting, I gave the Barry Brenner Memorial Lecture for inventing the SGLT2 class of drugs. And Dr. Brenner is the person that's responsible for explaining how these drugs work. And I'll take you through that in a second. So how does empagliflozin work on the heart to protect your heart, okay? Well, these drugs are very good at reducing the afterload, what your heart is pumping against. Because I said, they decrease the blood pressure, and they're very good at decreasing the preload, because I put you into a little bit of negative salt in water balance. So the heart now, by decreasing simultaneously, very quickly, the preload and the afterload, that really takes enormous stress off the myocardium. Now, if I decrease the blood pressure and I decrease the volume, the normal response is your heart rate to go up. But in none of the SGLT2 inhibitor studies have we ever seen an increase in heart rate. And so this suggests inhibition of sympathetic nervous system activity. And in fact, we've shown this using tritiated epinephrine. The other thing that these drugs do is that very, very quickly, within 2 to 3 weeks, they markedly decrease arterial stiffness. So what are your heart pumping against? It's pumping against the aorta. And the blood pressure in the aorta here, the pressure is much greater than the blood pressure you measure out here. And so when you see a 4 or 5 millimeter systolic drop here, at the level of the heart, you've decreased the aortic pressure by about 10 millimeters of mercury. So this is an enormous afterload reducer. And as I've said, oops, go. For whatever reason, the clicker stopped working. I don't know if the battery's dead, if you have a new clicker, but if you could advance the slide, the next thing that will come up is that there's a decrease in the sympathetic nervous system activity. So can you advance the slide over there, or can you get me a new clicker, one or the other? Now, the other thing, so I think that this is a major mechanism of cardio protection. The other thing that these drugs do is they change the substrate metabolism. Can you just forward? I'm sorry?
It's working.
Oh, it's working now? Oh, okay. There goes the okay. The other thing that these do is they change substrate metabolism. So if I acutely drop your glucose concentration, okay, your cells are used to metabolizing glucose, but now I just starve them. So what happens? I stimulate lipolysis, the plasma FFA level goes up. And now your liver starts burning free fatty acids. So what's the end product of free fatty acids? It's ketones. Ketones are very avidly taken up by the myocardium. Actually, ketones are taken up more avidly than glucose. And when you burn ketones by beta oxidation, so remember palmitate, you all remember this for your biochemical days, fatty acid, 16 carbon compounds, you chop off 2 carbon compounds as an end. You remember all this? Sure. But now you'll remember it. And you end up with ketones. So ketones are a preferred fuel in the myocardium. And we've shown that if, in fact, using PET and FDG, that if you take people with type 2 diabetes and you physiologically increase the plasma ketones, this markedly increases cardiac contractility and cardiac output. So I think these are the two major mechanisms. But there are a number of other good things that these drugs do. They improve insulin resistance, and your myocardium is very resistant to insulin. They lower glucose. You get weight loss, and you mobilize fat out of the myocardium. I'm not a big believer in the uric acid hypothesis in cardiovascular disease, but these drugs, sodium and glucose and uric acid, are co-transported in the proximal tubule, so I reduce uric acid. These drugs activate the angiotensin 1-7 system. This is the protective angiotensin system in your heart. They decrease inflammation, oxidative stress, and they decrease LV mass and the number of sodium proton pumps. So there are many, many mechanisms that are potentially involved, but I think the two primary ones are the hemodynamic benefit and the substrate shift to ketone metabolism. Now, what about SGLT2 inhibitors in diabetic kidney disease? So when I started my work with these drugs, I predicted, based on the Barry Brenner hypothesis, who's a very famous nephrologist at the Peter Bay Brigham Hospital in Boston, that these drugs would save your kidneys, okay? None of us knew or even suspected we would get the cardiovascular benefits that I just told you about. So all of the benefit on the heart, that came as a surprise. But the effects on the kidney, I predicted, and that's one of the major reasons why I got the Barry Brenner Memorial Lecture Award at the ADA, okay? So what have we learned about empagliflozin in patients with chronic kidney disease? It's a very big study, 6,600 individuals. Look, type 1s as well as type 2s. These drugs are not approved in the United States for treating type 1s. But if you have kidney disease, they are actually approved. The major side effect is you can get ketoacidosis, euglycemic DKA with these drugs, and that's why the FDA hasn't approved them for general therapy. But for kidney disease, you can use them. To get into the study, you had to have either a low GFR or a moderate reduction in GFR plus a high urine albumin to creatinine ratio, okay? And then you're going to get relegated to empagliflozin and placebo. It's a 2-year study. And the primary endpoint is having your GFR, doubling your serum creatinine, ending up with end-stage renal disease on dialysis or transplantation or renal death. So this is composite endpoint. And what was the hazard ratio for the composite endpoint? 0.72, meaning there was a 28% reduction in that composite renal endpoint. And you could see the separation of these curves. It took a little bit longer than the cardiovascular benefit, but you could see the benefit at the beginning of year 1. And not surprising, this drug got very quickly approved by the Food and Drug Administration. And now, if we look at the individual components in this chronic kidney disease study, the primary endpoint I already showed you, highly statistically significant. Progression of chronic kidney disease was slowed. The number of people entering up on dialysis was markedly reduced. You can see the hazard ratios 0.7 to 0.8. Cardiovascular death was decreased, and hospitalization for heart failure was reduced. So this drug in a high-risk population with chronic kidney disease saved your kidneys, and it also saved your heart, okay? So how do these drugs work? So this is what we call the hyperfiltration hypothesis that was put forward by Dr. Barry Brenner in Boston many, many years ago. So you can look at the slide. I'm going to speak it, and you can see with your eyes what I'm speaking, okay? If you're a type 1 diabetic patient or a type 2 diabetic, your blood glucose is increased. Now, that means you're going to filter more glucose. In the proximal tubule, okay, you are going to increase glucose reabsorption because you filter more glucose. And that's going by the SGLT2 transporter. And when you take back the glucose, you take back sodium with it. So now in the light blue, that means less sodium is going to go to the juxtaglomerular apparatus. So the kidney says, oh, I'm seeing less glucose. I must be hypovolemic. So 2 things are going to happen. I'm going to send a signal to the afferent arteriole, and I'm going to say, push more blood flow into the glomerulus. And that's good. That's an increased GFR, but it's going to increase the pressure within the glomerulus. The second thing it says, on the little efferent arteriole, the little arteriole coming out of the kidney, it says constrict. And when you do that, that increases the GFR, but it also increases the intraglomerular pressure. So the net result is shown in the bottom in white. You get hyperfiltration, renal hypertrophy, and increased intraglomerular pressure. And this is what damages your kidney. I'm going to show you this now schematically because this concept is very important. So here's the afferent arteriole coming into the kidney. It arborizes, breaks up into this glomerular capillary cleft, and then you have the efferent arteriole coming out. So what Dr. Brenner showed was when I treat you with an SGLT2 inhibitor, I decrease adenosine in the kidney. Why is that important? Adenosine is a powerful vasoconstrictor. I decrease adenosine, I increase blood flow to the kidney, and in type 1 diabetics in animal models, the SGLT2 inhibitor works in the afferent arteriole. Well, what happens here at the efferent arteriole, I increase the sensitivity to angiotensin 2, and that increases the glomerular filtration rate, but at the expense of increased pressure. And you all know you can treat with an ACE or an ARB. So this was the ongoing theory until we actually now move from type 1 diabetics. Everything I told you before is true. Type 2s. In the type 2s, the SGLT2 inhibitors don't have their primary effect here on the afferent arteriole. They work on the efferent arteriole. It doesn't make any difference whether they work on efferent. I decrease the intraglomerular pressure, and on a long-term basis, that's going to save my kidneys. Now, when we think about diabetes and diabetic kidney disease, this is the Brenner hypothesis. It's called the tubular glomerular feedback hypothesis. And everything I told you is absolutely correct. Everything that Dr. Brenner said was correct. But the fact is, diabetic kidney disease is much, much more complicated. And you can see there's an ominous octet for diabetic kidney disease. It's not as simple as people think. So yes, there clearly is an increase in intraglomerular pressure. But if you really want to stop diabetic kidney disease, we spend an enormous amount of time. We see a patient, the GFR is 30. We put them on all of these drugs, and it's very costly. Why don't we just simply correct the basic problem? You don't get diabetic kidney disease if your glucose is normal. So if we prevented the hyperglycemia, you would never get diabetic kidney disease. You would never get diabetic retinopathy. You would not get diabetic neuropathy. Do we spend enough time up front controlling the glucose? Absolutely not. That's why we see the patients with kidney failure and eye disease. Second most important factor that accelerates diabetic kidney disease is your blood pressure, okay? So what is considered a normal blood pressure if you have diabetic kidney disease? It is 120 over 80. It is not 130 over 85, okay? All organizations now agree. Normal blood pressure, 120 over 80. And we really get to that, okay? Next on the list is hypoxia, okay? So why? In the proximal tubule, you reabsorb this glucose with sodium. Sodium cannot remain in the kidney cell. It has to be pumped out by the sodium potassium ATPase. And that's very energy requiring. So the kidney is hypoxic. This leads to inflammation, fibrosis. This leads to glomerular disease, okay? Podocyte dropout. The podocytes are the cells that sit on the glomerular basement membrane, and with the little foot processes, they prevent albumin from getting into the glomerular tuft. Hyperglycemia damages the podocytes. Albumin gets into Bowman's capsule. This causes mesangial hypertrophy, endothelial dysfunction, and tubular damage, okay? A very important cause. Next on the list here, obesity. How many lean diabetics do you have in your practice? I don't see them anymore. All my diabetics are obese. This is a whole new concept. This is the concept of lipotoxicity. I believe that at least half of diabetic kidney disease has got nothing to do with glucose. It has to do with fat deposition in the kidney. And so if you can get people to lose weight, you will protect their kidneys, okay? Just as if you can get people to lose weight, you'll protect their liver from MASH. I'll come back to this. And then this tubular growth factor hypothesis, okay? So the earliest abnormality in diabetic kidney disease is not in the glomerulus, it's in the tubules. You see tubular hypertrophy. And those tubules release growth factors that cause the glomerular hypertrophy. Well, the pressure within the glomerulus is proportional to the radius. So as the glomeruli got bigger, and diabetics have, and particularly if they're obese, have big glomeruli, that increases the intraglomerular pressure. And then lastly, the thing you can't do anything about is the genes you inherited from your parents. So if you choose your parents unwisely, you're stuck with all those genes for the rest of your life, okay? So SGLT2 inhibitors, wow, look at that. They correct 7 of the 8 problems. The only thing that they don't do is give you some new parents with some new genes. I haven't figured out how to correct that problem, okay? So before you're born, check out who your parents are going to be. You may want to change them, okay? So you have now a drug that's correcting 7 of the 8 problems in the kidney. It's going to be an enormous beneficial drug. And I showed you the huge benefit you get with the empagliflozin study. Now, what about MASH and MASL? So over the years, we've had a big interest in this. And we were the first people to show, this is a New England Journal of Medicine article, some 15 years ago. What is the best drug in the world for treating MASH and MAFL? The gastroenterologists still don't get it. They get it, they don't want to acknowledge it. Why? The best drug in the world for treating MASH and MAFL is pioglitazone. And that's a New England Journal of Medicine article about 18 years ago. So why do the gastroenterologists don't want to promote this? Because pioglitazone is $5 a month. These newer drugs that are being developed are like $2,000 a month, okay? And I've talked to the FDA about this. All these new drugs that are being developed for MASH, they shouldn't go against placebo. They should have to go against pioglitazone. And I guarantee you, none of these drugs will beat pioglitazone. $5 a month, okay? It's now, you can get it for free because probably here in India, they throw the tablets away. They've been around so long. So this is now what empagliflozin EMPA does on ALT, and this is in the EMPA-REG outcome trial. And you can see, compared to placebo, you see a nice drop in the ALT, and the higher your ALT, and I could show you the same thing for AST, the higher the ALT, the greater the drop. Now, we've gone on and we developed techniques to measure liver fat using MRI PDFF, okay? And this study, these are diabetics with MASH and non-diabetics. And you can see that empagliflozin markedly decreases liver fat by about 2.5 to 3%. Pioglitazone will give you a much greater decrease, but nonetheless, this is a quite clinically significant decrease in liver fat. So there's a lot of interest that's been generated by our studies about using these drugs in combination with GLP-1 receptor agonists and pioglitazone in people who have MASH. And if you look at the change in body weight and the change in liver fat with empagliflozin in our studies, you can see they're very well correlated. The more the change in the body weight, the more the decrease in the liver fat. Just getting fat out of the liver, and there's an inverse correlation with the Matsuda index of insulin sensitivity. So the more insulin resistant you are, the more liver fat you have. And when I treat you with empagliflozin, I improve insulin sensitivity. I also get rid of the liver fat, okay? So what are some of the possible mechanisms for lowering this liver fat? Well, you lose weight. I showed you lose about 3 kilos, so you're going to lose weight in the liver as well. This improvement in insulin sensitivity is related to burning fat in the liver. I increase fatty acid oxidation. I decrease liver fat. And direct improvement in the insulin signaling transduction system would be expected to mobilize fat out of the liver. So in summary then, if we look at the benefits of empagliflozin, these drugs are very good at lowering your A1C. As I showed you earlier in the presentation, empagliflozin is very good at improving beta cell function and reducing the insulin resistance. I get weight loss, a nice drop in blood pressure. Many studies now showing the cardiovascular protection and the heart failure protection. We have a beautiful study showing renal protection, and our preliminary data that I've showed you that's published suggests there may be also some benefit in terms of steatosis and fibrosis in the liver. Retinopathy has not been looked at, but I'm quite certain because of the changes in retinal blood flow that occur, these drugs would be very good at looking at diabetic retinopathy. And the other benefit is they work on the kidney, different from any other anti-diabetic drug. So you can combine empagliflozin with any of the other drugs, and these are very safe drugs. So the major side effect that you will see is that in ladies, there's about a 6% increase in all of the big studies in vaginal mycotic infection, compared to 2% in the placebo group. Hygiene is critically important, okay? You need to talk to the lady. You need to explain to them. They actually need to wipe themselves very, very carefully after they've urinated. And in men who are not circumcised, there's an increase in mycotic infection. There's a major, major misconception that these drugs increase bacterial infections. They do not. In every big study with every SGLT2 inhibitor, we have never seen an increase in bacterial infections in the bladder. there is clearly an increase in vaginal and penile mycotic infections. This is very different. You can treat these mycotic infections with local cream or tablets very effectively, okay? So key take-home messages. Empagliflozin has really good glycemic efficacy, okay? It decreases cardiovascular death and hospitalization for heart failure in patients with both reduced ejection fraction and preserved ejection fraction. Very, very good data showing protection of your kidneys on a long-term basis, okay? So empagliflozin, this is a cardio, kidney, renal, metabolic drug. And it should be used as first-line therapy. By who? Everyone. Okay, whether you're a primary care doctor, internal medicine doctor, you're an endocrinologist, a cardiologist, nephrologist, is your friend. This drug does not cause hypoglycemia. The side effect profile is very, very good. And you get all kinds of protection from this class of drugs. So I'm going to stop at this point, and we can open it up to questions from our distinguished endocrinologists up front, anybody in the audience, and I think people who are listening in also can ask questions as well, and I'll try to answer them. Again, thank you for your attention.
If you have any questions, you can pass it on, or maybe you'll get a chance to ask them directly after that.
We'll invite them first.
Okay, perfect.
We'll be winding up.
Probably
Yeah.
they'll begin from Patna.
Sounds
and
good to me.
a chance to us from Patna to Chandigarh. And so if you have any queries, you put it across to the legend himself, if you can.
Questions?
I request you to kindly connect to the center. The Chandigarh center first for the first question.
Hello.
There we go.
Dr. Bhatia, I'll just be asking regarding the MASH.
Achha, before that, due to some unavoidable circumstances, Professor Dr. Ashok Kumar, he is not able to make it up. Instead, we have Dr. A.K. Thakur. I request, sir, he's a DM cardio, gold medalist, senior interventional cardiologist at Health Heart Clinic, Boring Road, Patna. Kindly come on stage.
Yeah.
And I request Dr. Ranjit Kumar to kindly felicitate.
Come on up. Can't hide back there. Yeah. They want to take a picture here. We have to smile.
Right. So over to the question answer session. Yes. I request you to kindly sit down, sir.
So I would be asking regarding the MASH resolution. So regarding the current status of SGLT2 as GLP-1 vis-a-vis in MASH resolution, what is where exactly it stands in the actual standing? It does well. We got to know from D. Fronzo, sir, but where it is in the guidelines and how it really fits in.
Yeah. So I can repeat the question and make sure I understand it. He's asking in terms of MASH and MASL, where do SGLT2 inhibitors and GLP-1 receptor agonists stand? Well, at the top of the list, the American Diabetes Association now has made a clear statement, finally, that first-line therapy for treating type 2 diabetic patients should be a GLP-1 receptor agonist. And I would completely agree with this with one problem. Monotherapy, even with the GLP-1 receptor agonist, in my opinion, is not sufficient. So if I were writing the ADA guidelines, I would say the treatment of diabetics in general should be a GLP-1 receptor agonist whichever one the insurance company will pay for, an SGLT2 inhibitor, whichever one the insurance company will pay for, and pioglitazone. It should be triple therapy from the beginning. Now, in terms of potency, we already have a Novo study with semaglutide showing a very marked positive benefit in terms of regression of fibrosis and also regression of steatosis. And in the United States, Ozempic semaglutide is approved for treating MASH and MASL, okay? I suspect that tirzepatide will also eventually get approved when they finish their study. SGLT2 inhibitors, as I showed you, are beneficial. You get about a 3 to 4% decrease in liver fat, but they're clearly not as powerful as the GLP-1 receptor agonists. But the main reason you're going to be using these drugs is to lower the A1C to protect your kidney and protect your heart. So sort of as a beneficial side effect, you're also getting the protective effect on the liver in terms of protection against steatosis in the liver and fibrosis in the liver. But in my opinion, the two best drugs for MASH are going to be GLP-1 receptor agonist and pioglitazone. Pioglitazone, I might also say, pioglitazone is not approved by the FDA for MASH and MASL, even though I think the data are pretty clear that it works. Sorry. Yeah.
One more small question regarding the mechanism of action of SGLT2. You told multiple things. How do you come to some kind of conclusive evidence about any of them?
Well, at the level of the heart, I think it's the hemodynamic benefit and shift to ketone metabolism. At the level of the kidney, I think it's multifactorial. And all of those 7 mechanisms that I showed you are critically important. If I had to pick one, I would say is the decrease in intraglomerular pressure as was hypothesis from the Brenner studies many years ago. But as I said, there are at least 7 different mechanisms that I think are important in the kidney. If you force me to pick one, I would say decrease in intraglomerular pressure.
Thank you. From Chandika.
So, one more question. Can SGLT2 inhibitors be used in hypertensive kidney disease, especially with albuminuria? Only with albuminuria.
What?
Hypertensive kidney disease with albuminuria. Can we use SGLT2 inhibitors in those patients? What is the
Oh, absolutely. They would be a great drug to be used in diabetics or even in non-diabetics. Now, I should point out that these drugs are very effective in kidney disease, diabetic etiology as well. The only type of kidney disease that was excluded from these studies is polycystic kidney disease for strange reason. But people who had IgA nephropathy, glomerulonephritis, membranous GN, et cetera, they all benefited from the SGLT2 inhibitor therapy. So yes, hypertension as well, because these drugs not only going to have the direct effect on the kidneys, but they're lowering your blood pressure as well.
Thanks, sir. Now we can have Mumbai. May we connect to Mumbai, please?
Yeah. Good evening, sir. I mean, we had the pleasure of listening to you for the last 1 hour or so, and we were in fact eagerly waiting for your lecture. We have a couple of questions coming from the Mumbai division, and one of which is when we decide to combine empagliflozin with a DPP-4 inhibitor, which one will you suggest, whether it is linagliptin, sitagliptin, or any other gliptin that you can think? Though I understand that you were with Boehringer and then it will be an EMPA and Lina combination, but whether an EMPA and Sita will also be useful.
Yeah. In my opinion, all DPP-4 inhibitors are equivalent. The only benefit is using linagliptin is you don't have to adjust the dose in people with renal disease. So again, I would say whichever drug is the cheapest of the DPP-4 inhibitors, that's the one that I would use. But to be quite honest with you, In my practice, I haven't used DPP-4 inhibitors for a long time. So all the mechanism of action of DPP-4 inhibitors studies were all done by me. But at the current time, I am using the GLP-1 receptor agonist. So once you're on a GLP-1 receptor agonist, you would be no need to have the person on a DPP-4 inhibitor. The big problem with the GLP-1 receptor agonist, of course, is cost. So Ozempic and Mounjaro, with the two big ones in the US, they're $1,000 per month. So you can imagine that many, many patients, because of cost, cannot afford these drugs. DPP-4 inhibitors, now they've been around for a long time, are a lot less expensive, but they don't give you renal protection. They don't give you cardiovascular protection. And the A1C drop is not as good as the GLP-1 receptor agonist. So you always have to take all these things into consideration. And quite frankly, cost is a huge obstacle. Linagliptin in the United States has just gone generic. So the cost has come down, but linagliptin is not nearly as effective as either tirzepatide or semaglutide. My understanding here is in India. India is the copycat capital of the world. Even before drugs come to the market in the US, you had the copycat here. So my understanding is both tirzepatide and semaglutide are available here in India, and they cost a lot less than in the US, but they're still expensive nonetheless. So cost is always going to be a huge issue, and you just have to decide what your patients can afford and not afford.
Okay. Another question is the effect of empagliflozin on the dyslipidemia in diabetics. So we have not really touched upon that. Whether they
Yeah. These drugs are pretty neutral on the lipid profile. So you're not going to see much benefit or any deterioration in the lipid profile. So I don't really see that as an issue in deciding. If you have hypercholesterolemia, we have statins, and I'm a big believer. My LDL cholesterol is 48, my triglyceride is 45, and my HDL is 92. So I'm a big believer your LDL cholesterol, I have been for over 15 years, should be less than 50, 55. Actually, I think lower is better. So if you have hypercholesterolemia, we have good drugs. Hypertriglyceridemia, this is a very controversial topic in treating diabetics because all of the fenofibrate, those studies have all been negative, the field study, although maybe one of the fish oils, not because it lowers triglycerides, but has other effects, EPA may be of benefit. But treating dyslipidemia is important for atherosclerotic issues. I do believe that the dyslipidemia contributes to the renal disease, but you're not going to see much benefit or either good or bad way with empagliflozin or any of the other SGLT2 inhibitors.
One last question, sir. It's related to when we really need to stop empagliflozin, say in an acute intensive care unit setup or when undergoing a surgery, whether we need to stop.
Yeah, so you clearly need to stop. There is a risk of euglycemic diabetic ketoacidosis. So these drugs, I told you, because they switch you over to burning fat, there is an increase in virtually every patient. Usually it's quite small in the ketones. But remember, when you're stressed, glucagon goes up. That drives ketogenesis. Catechols go up. That drives ketogenesis. You become very resistant to insulin. So insulin's not working. So in the intensive care unit, that's where you have to worry about the development of ketoacidosis. So anybody who's on an SGLT2 inhibitor, it clearly must be stopped. Once the acute problem is now corrected, then you can make a decision to restart the SGLT2 inhibitor. It's a good question.
Thank you so much, sir.
Yeah.
Thank you. Now we connect to Ahmedabad, please.
Hello. So my question is to you told that we had a bacterial infection with the SGLT2 and mycotic infections. And mycotic infection, really, it is not a dangerous, but suppose the patient having a pyelonephritis, then we can, after treating the pyelonephritis, we should restart the SGLT2 or not?
Yeah. So remember, there's an increased incidence of pyelonephritis in diabetics in general, whether they're on metformin, pioglitazone, or any drug. So in my opinion, it has never been established that these drugs, the SGLT2 inhibitors, increase the incidence of pyelonephritis above what you would expect in a diabetic population who's not on one of these drugs. And as I said, if you look, if you don't believe me, you can look at all the studies. You will never see an increase in the incidence of bacterial urinary tract infections. Now, obviously, if you have such an infection, you need to think about, do I want to restart the medication? So personally, if I had someone who had pyelonephritis, I would be working them up to see if, in fact, they had a prostatic issue and bladder emptying problems, whether they might have renal stones or some kind of obstructive uropathy. If everything's okay in the urinary tract and the drug is clearly beneficial to the patient, after a couple of weeks, I would not feel uncomfortable about restarting the drug. Of course, if you got two episodes, then for sure I would not continue the drug. But one episode would not deter me from restarting the drug.
And while the patient is on the having a genital mycotic infection, that time we have to discontinue or we have to continue the SGLT2?
Should we discontinue the drug or need to continue in presence of mycotic infection?
And which ones?
Mycotic infection.
Oh, with mycotic infections, I don't worry too much about that. Then you need to re-emphasize whether it's a guy or a gal, cleanliness is very important. You can treat this locally with a cream or Diflucam with a tablet. If you now have a repeat infection, then you need to discuss with the patient. You need to tell them, look, this drug is helping your kidneys, this drug is helping your heart. You've had 2 vaginal infections. My suggestion is we continue the drug, but if this is an annoyance to you and you feel uncomfortable, then we'll find other drugs to treat you with. This decision that needs to be made with the patient. But the benefits of the drugs of this class and empagliflozin is so good on your heart, your kidney, and lowering glucose that I would try to encourage the person to continue to take the drug. But occasionally you have people who just have recurrent vaginal or penile infections in uncircumcised males, and the patient may decide they just don't want to be on it. But that's something you need to decide with the patient.
And also empagliflozin in the cardiac patient as well as the kidney patient, dose is 10 milligram. And for the diabetic is 25.
Yeah. Yeah, it's a little stupid. So you are correct. All of the cardiovascular and renal studies were done with the 10 milligram dose. So strictly speaking, if you go by what the studies did, you would put the person on the 10 milligram dose. But you definitely get a little bit better glucose lowering, A1C lowering with the 25 milligram dose. And I have no reason to believe that you wouldn't get the same cardiovascular renal benefit on the 25 milligram dose. So I always use the 25 milligram dose, even though in all of the big studies for heart and kidney, they use the 10 milligram dose. Actually, I told you I was the major consultant for Boehringer when these studies were done. And I actually recommended that they don't use the 10 milligram, they use the 25 in all of the big studies. So it's a little conflicting and paradoxical, but personally, I would go with the 25 milligram dose.
Okay. And upper cap of the dose is empagliflozin is 25 or we can go higher also?
No, 25, that's it. There's no study that's gone above 25. Now, I can take you the other way because most of these drugs, and this is true for all the SGLT2 inhibitors, they had a lower level of GFR that they didn't allow patients in. So if your GFR was less than 20 or 25, that wasn't an inclusion criteria. But there are data Actually, the first data came from George Baccaris with canagliflozin, and they're very similar data with empagliflozin and dapagliflozin. Even in people with a low GFR, 10 or 15, which is less than the inclusion criteria, there's clearly benefit. So in my opinion, you should be on the drug until the day you walk into the dialysis unit. And there are two big studies going on now, even in people who are on dialysis, because there are benefits in terms of heart failure in the heart, looking at these drugs in people who are on dialysis. Those studies are ongoing. But if your GFR is 10, you still should be on the drug until you end up actually ending up on dialysis, at which point I would discontinue the drug. But you, in my opinion, can go lower than what was approved by the FDA.
My question is, if GFR is less than 30, still the dose can be 25 milligram per day, or we should decrease the dose?
No, you can stay at 25. There's no data that there's an increase in side effects or difference between the 10 and the 25. Yeah.
Okay, thank you. Good night, Ahmedabad. So now it's turn to the hosts again. So we have to give priority to the guests. So your questions are welcome. Dr. Haq, please.
This the reduction of the reduction CV death rate is around 38% with this molecule, empagliflozin.
Yeah.
But it's not so with DAPA. So do you consider it as a molecule effect or a class effect?
Yeah. So this is
second question is that.
Let me take one question at a time, okay? So what he's saying is that if you look at the EMPA-REG outcome study, the reduction in cardiovascular death is much greater than was seen in, say, the canagliflozin study or the dapagliflozin study. But this is very, very misleading. So to get into the EMPA-REG outcome study, 100%, actually it's 99.9% of the people had a previous cardiovascular event. So they're at the very highest risk. In the DECLARE study, 2/3 of the people actually had not had a cardiovascular event. They got in because they had risk factors. And in the canagliflozin study, it's about half of the people had cardiovascular events. So you get the greatest benefit because of the patient population with empagliflozin, the least benefit in that endpoint in DAPA, and intermediate with canagliflozin. In my opinion, these drugs are all equivalent. The pharma companies always hate when that question comes up and I have to answer it. But in my opinion, they're all equivalent. And in all honesty, when I sign my patients out, and this is true for GLP-1 receptor agonist, SGLT2, I write GLP-1RA, SGLT2 inhibitor, and the ward clerk who's signing the patient out looks to see what the insurance covers. Because if you write a drug that's not covered by the insurance, the patient's not going to get it. So these are all very, very good drugs, but the patient has to be able to afford it and be on the drug. So cost is very important. But I don't believe that there are any differences in the cardiovascular benefit between empagliflozin and dapagliflozin.
Second question?
Yeah, you have a second question.
Oh, I think you answered the second question because in ADA 2026 or 25, they recommend that patients with diabetes and ACVD, 2 gliflozin they can recommend. One is EMPA and another one is canagliflozin. They don't recommend DAPA.
Yeah.
In heart failure, they recommend everything, all the 3, and in the CKD also.
Yeah.
But why they recommend only 2? This EMPA and
Because I'm not the president of the ADA, and that's the major problem. So, as you may know, I have a history of disagreeing with everything that the American Diabetes Association does. Until our edict study, they never recommended combination therapy. They still don't put pioglitazone. I've been asked to be president. I've served in every level of the ADA. I've not been president. I've been asked many times. And I say, well, I'd like to be president. And they always say, but you know, Ralph, you have to endorse our algorithm. And I said, but I don't believe in your algorithm. So if I have to endorse and say something I don't believe in, I won't be president of the ADA. Look, the ADA has taken we've had all these huge studies with GLP-1 receptor agonists showing cardiac benefit, with SGLT2 inhibitors showing cardiac and renal benefit. And it's not until 2 years ago. We've had these studies for 10 years. They finally said, they always had metformin as first-line therapy. That's crazy. I would never put metformin as first-line therapy, okay? Metformin is number 4 on my good list. So finally, 2 years ago, they said, if you have heart disease or heart failure, then you should be using a GLP-1 and SGLT2. I started doing that 15 years ago, okay? And then they said, if you have kidney disease, you should prefer SGLT2. That part is still wrong because we have now good data with GLP-1s that they protect your kidney. So they need to add GLP-1 under kidney as starting drugs. So yes, they're moving forward, but very slowly, okay?
But
most of the older diabetic patients have prostate problem and they complaining of micturitia, difficulty in passing urine or burning micturition. So in this type of patient, can SGLT2 inhibitor continue or withdraw or on and off?
No, I would, that is, I have to say, I run into this problem in my patients as well. People who have prostatic hypertrophy and obstructive uropathy a little bit, that because the drug makes you pee more, particularly in the first 48 hours, the people find a big increase in urinary frequency. They have to get up more times during the night, avoiding small amounts. They find it annoying. Now, usually, if you can get past the first 48 to 72 hours, then it evens out because you're not in this continuous negative salt and water balance. But there are some patients that find it very annoying, and they may not want to continue on the drug. So that potentially can be an issue with BPH, yes.
The Canada showed these risks of amputations. Empatrol didn't show. So was it an individual effect of Canada causing increased amputations?
amputation, he's talking about.
Amputations of canagliflozin. Okay, so unfortunately, in the early studies with canagliflozin, and in fact, there were 2 studies back to back, there was an increased incidence in amputation. And it was a statistically significant increase. And because of that, people basically in the United States stopped using canagliflozin, and no one really uses it anymore. Now, I can't prove this, but personally, I think that was just bad luck. I don't think that canagliflozin increases the incidence of amputation. And I can tell you that there are at least 10, 15 other studies with canagliflozin where there was no increase in amputation. It just happened in the 2 big cardiovascular outcome studies, there was an increase, and that drug basically is non-existent in the United States. We don't see any increase in amputation with any of the other SGLT2 inhibitors, including empagliflozin and dapagliflozin. That's another reason why I don't believe that Cana really causes amputation, but bad luck for them. Yeah. Again, that actually came up in some animal studies with canagliflozin as to whether that canagliflozin may increase the incidence of bone thinning, osteopenia. This has not been shown with either empagliflozin, dapagliflozin. So I'm not concerned about bone health. These drugs really, on a long-term basis, don't increase calcium excretion. They don't affect PTH or vitamin D metabolism. So that concern that came in animal studies with canagliflozin, I don't believe is a clinical concern with empagliflozin. Yeah.
And that signal of amputation was not there even in the Credence trial.
Yeah.
So they had done the Credence and it was not there even in
Correct.
Credence with Cana.
Yeah.
A question to you about the use of these drugs in patients with foot ulcer. Patients had foot ulcer in
Yeah.
the past, and should we go for these drugs in those patients?
Yeah, I wouldn't be concerned in people who have foot ulcers. Particularly if they have a decrease in GFR, which many of these people will, the drug is going to be beneficial in terms of the kidney. And there's no evidence that it in any way interferes with wound healing. So I wouldn't be worried about using it in this population.
Okay, we were just discussing about the primary therapy in type 2 diabetics, and we mentioned about the GLP-1.
Yeah.
We were particularly having this talk on CKM in type 2 diabetic patients, and we do have patients with a lower BMI.
Yeah.
And we are more prone to develop CKD, although more of overall fat, so that is okay.
Yeah.
So with that lower BMI and the sarcopenic obesity which we have, the truncal obesity meaning, it is
Yeah.
not the overall BMI.
Yes.
So with that in mind, where do you keep these molecules vis-a-vis GLP-1 in day-to-day practice? So just positioning of therapy.
A very important and controversial question and answer. Okay. So what he points out is that if I put you on, let me use the two newer ones that give you a lot of weight loss. So Ozempic, Mounjaro, you lose 25% of your body weight. You also lose lean muscle mass, okay? Lean muscle mass is equated, you lose lean body mass. That's equated with muscle mass. That may not always be the case, but let's assume you lose lean body mass. You always lose lean body mass about 30% of the total body weight, okay?
Yeah.
And if I put you on a diet and you stop eating and you lose weight, you will lose lean body mass in the same proportion as I put you on this drug. And that is in a typical diabetic patient who has, say, maybe 45 to 55. So I don't believe that the decrease, if you lose weight, you don't need the muscle to carry things around. What's in the literature, in my opinion, does not suggest that there's any deleterious effect. In fact, all of the data show that muscle function, VO2 max, everything improves when you lose weight, which is telling me that the decrease in muscle mass is not a problem. So who do you have to worry about, okay? If you are an older person, 70, 75, 80, there's an age-related decline in muscle mass. And now in this population, maybe that additional muscle mass you lose with the GLP-1 could become a problem. That's not been studied. That's one group. Second group is the group you talk about, Indians. So I've trained a lot of Indian doctors, and in India, people are basically on a protein malnourished diet. They're on a vegan diet, and the protein that's in the vegan diet is not the best protein for building muscle mass. So most of the endocrinologists I know have their diabetic patients on a protein supplement. Using the GLP-1s in this population could potentially be a problem, but it's not been studied. The third group in whom the decrease in muscle mass may be a problem are the yo-yos. The people, they lose weight and they lose muscle mass. And then if you stop the drug, you're going to regain all the weight. And so now they regain all of the weight. Maybe the increase in muscle mass is not in proportion to the weight regain. And then they lose the weight. They keep going back and forth. That's another potential high-risk population, which also has not been studied. So I believe the elderly population, the typical type Indian who has more central obesity and not the global type obesity, and then the people who lose and gain weight, we need to look more carefully about what this decrease in muscle mass gets translated to, and really hasn't been studied. We have a very large grant with Regeneron, and we're looking at this quite specifically right now. Maybe next year I can give you the answer to your question.
Sasi is a nephrologist over there.
Yeah.
You will.
Before I
So Sasi.
Yes, go.
on behalf of all of us, I must salute you for giving us ominous object theory.
Thank you.
So every diabetic presentation start with ominous object.
Thank you. It's important because if you got 8 problems, I can add a couple of more. The point is, and I've been saying this for 15 years, the ADA doesn't catch on. 8 problems, one drug not going to correct 8 problems. Very simple.
My question is, if a person is having HbA1c of less than 8, and he has enjoyed all the lifestyle modification, still his HbA1c is not less than 8. So
Yeah.
what drug you suggest? You suggest metformin alone, or SGLT2 inhibitor, or both, or triple drug?
Now, if you're talking about a person who's not being treated and they're not on any medication, they have an A1C let's say, is between 7 and 8, every one of those patients at the Texas Diabetes Institute would get triple therapy from day one. So if you look at the edict study, the lowest A1C was 6.5, the highest A1C was 14.4. In the edict study, because remember, we started this study a long time ago, they got triple therapy with metformin, exenatide, which is a really old-time GLP-1, and pioglitazone. If I were to do the edict study again today, which is what I do clinically, everybody would get on pioglitazone. Everyone would get on if cost was an issue, they'd get on Ozempic or Mounjaro, and they would get on an SGLT2 inhibitor. So we use triple therapy in all of our patients. Metformin, at the Texas Diabetes Institute, we see 10,000 unduplicated diabetic patients annually. It's a 173 square foot building. We have all of cardiology, nephrology, we have dietitians, etc. And 80% of our people are below the poverty level. And we have a contract with the government. We basically get all the drugs free. So I don't have to worry about cost. So all of our patients really are on triple therapy. At the university where all the rich people are, we give better treatment down at the Texas Diabetes Institute for the poor people than the rich people, because the rich people have to pay for the drugs. And $1,000 a month for Mounjaro is very expensive. At the TDI, the government subsidizes all of this, and the local health county does. So they basically get Mounjaro and Ozempic for free. So triple therapy is the way we go, and all these people.
Message is well taken. So one last question. India is developing a large number of people who has got the pre-diabetes due to the increased use of processed food and probably the sedentary lifestyle. So what do you suggest for the pre-diabetes? Should we use drugs? Or it is still not proved by the trials that we have to use the drug? So what
this is a huge problem. So in the US, for every diabetic, there are 2 pre-diabetics. In India, for every diabetic, there are 2 pre-diabetics. And pre-diabetics, if you follow them long enough, many of them are going to go on to develop diabetes. So how do we treat pre-diabetics? If metformin has been used. First, there's no drug approved by the Food Drug Administration for the treatment of pre-diabetes. The FDA doesn't recognize pre-diabetes as a disease, so that no drugs are approved. What about the ADA? The ADA says if you're, and you're going to see I disagree with the ADA again, if you're at high risk, meaning you're younger, you're leaner, and the closer your A1C is to 6.5, 6.0 to 6.4, you should consider metformin. I disagree with that, okay? If you have prediabetes, and let's say you have a strong family history of diabetes and a strong family history of cardiovascular disease, I'm going to treat you. So how would I treat you, okay? If you are overweight and obese, the best treatment would be one of the newer GLP-1 receptor agonists. If you're lean and you can't afford the more expensive drugs, the best treatment would be pioglitazone, or low-dose pioglitazone with 1 gram of metformin. And we've published on all of this as well. So I'm a big believer in treating in high-risk people. High risk means strong family history of diabetes, strong family history cardiovascular disease. Not recommended by the American Diabetes Association, and none of these drugs are approved by the FDA. But with Ozempic and with tirzepatide, the reduction in the conversion rate of prediabetes to diabetes is 88% in the published data. With pioglitazone in the ACT NOW study, which is our study, the decrease in prediabetes going to diabetes is 75%. So metformin, it's 33% decrease. So I would go either low dose pioglitazone, 15 milligrams, 1 gram metformin, because they're very cheap. Or if you're overweight and you can afford the newer GLP-1s, I would go with the newer GLP-1s.
Thank you, sir.
Just to add, sir, the ACE guideline have come up with the treatment for pre-diabetes, and they have this algorithm of patients having single risk factor, you go for metformin and acarbose. Multiple risk factors, you go for pioglitazone or GLP-1 receptor agonist. Definitely, as you said, according to the body weight, you can choose.
Sounds reasonable.
And in the complication part, they have again done the same thing as they do in the treatment of type 2 diabetes. So if you are having pre-diabetes and having osteoarthritis, go for SEMA. If you are having OSA, you go for tirzepatide. So they have put it the algorithm like type 2 diabetes. So my question was to the nephrologist, and after the nephrologist, it will be definitely to sir, which SGLT2 in CKD and why?
So as sir has mentioned, they all have the class effect of SGLT2 inhibition. So again, the cost is a matter. But in India, we have almost similar cost for EMPA and DAPA. So cost is not a matter in India because they have similar cost. But load of studies with empagliflozin in CKD population. So as a nephrologist, I would prefer EMPA, but I think DAPA and EMPA has similar efficacy. Your take, please.
In my opinion, they're equivalent. Pharmaceutical companies ask me to speak for, they hate this question. The fact is, you block SGLT2 inhibitor, you're going to get the same effect with all of the drugs. I mean, my job is to tell you the truth. So I want you on an SGLT2 inhibitor, okay? In all honesty, the cost is the most important thing. Now, there is actually one other consideration. Now, I see there's some ladies here, so I'll make this gender equal. So for the guys, if you have a pretty young lady who comes to call on you from a pharmaceutical company, maybe you use her drugs. For the ladies in the audience, if you have a handsome young guy comes, maybe you use his drug. And maybe that's even more important than the cost. I don't know. So this is gender equal now, okay?
Sir, one query from me, sir. Sir, you said that there is no increased risk of bacterial infection with SGLT inhibitor. Many times we saw asymptomatic bacteria in our patients.
Yeah.
So can we start safely in those patients, or you take any extra precaution?
Yeah. So asymptomatic bacteria is actually very common. And there has been a large issue of treat, not treat. If it's asymptomatic, we generally don't treat. So I would say there's no contraindication. And I'm not aware of any evidence that says if you have asymptomatic bacteria, you're more likely to get a urinary tract infection if I put you on an SGLT2 inhibitor. But of course, if you decide to treat and you have a urinary tract infection, now you have to reevaluate. Of course, you got to stop the drug, treat the infection. Then you have to decide in your own mind, do I want to restart the drug? And I would probably restart the drug. But if you decided not to restart the drug, I wouldn't object to that.
Thank you, sir.
Pushna?
Sir, is there any chance of decrease of bone density with GLP-1
No, I don't think there's any evidence that there's a significant decrease in osteopenia or fractures. That issue primarily came up with pioglitazone. And the data are very clear with pioglitazone. If you're a postmenopausal woman, there is an increased incidence of bone fractures. It's small but significant. If you're a premenopausal woman or a man, there's not an increased incidence. So in my clinic, all postmenopausal women get a bone mineral density scan. And if they have osteopenia, I don't use pioglitazone in that population. But that's the only drug that I get concerned about bone problems with. Yeah.
So before the question by Dr. Anand, about the GLP-1 and
Sir, we have one. I have one question regarding progression of kidney disease in diabetics. There are several classes of molecules for to inhibit progression of kidney disease, like ACE inhibitor, ARB, then SGLT2 inhibitors, and phenylalanine. So, how do you choose the molecules? You use sequentially, or you use combination therapy?
The different drugs to be used in CKD management.
Oh,
the sequential or it's the
yeah. People with CKD, I treat them exactly the same as if they didn't have CKD. You need to protect their kidney, okay? So George Bacchus and I have published several papers on this. George is one of the giants in the nephrology field. And I'm a strong believer in the 4 pillars. So every person should be on an ACE or an ARB, okay? That is the original studies 30 years ago. You then would add an SGLT2 inhibitor. If you can afford it, within 2 weeks, I would add finerenone. And within another 2 weeks, I would add the GLP-1 receptor agonist. Now, this is all dependent, again, on cost, okay? We have good studies showing all 4 of those categories of drugs give you renal protection. So here's something that's not appreciated. If you look at the relative risk reduction with SGLT2 inhibitors, the relative risk reduction I showed you, the hazard ratio is 0.62, 0.65. That's a 35% relative risk reduction. The absolute risk reduction is never given in the papers. And I have a big objection to this. So the absolute risk reduction with the ACEs and the ARBs is about 1.5%. The absolute risk reduction with the SGLT2 inhibitors, that's the best. It's about 4 to 5%. The absolute risk reduction with finerenone is about 2 to 3%. And the absolute risk reduction with the GLP-1 receptor agonist is about 2 to 3%. So ACEs and ARBs, 1.5 to 2%. SGLT2, another 4 or 5%. That's 5 or 6%. Finerenone, add another 2%, 7 or 8%. Add GLP-1, you're up to 10 or 11%. Absolute risk reduction. What that's saying is 85% of the risk reduction is not explained. Why? Either there are a lot of unexplained risk factors that we haven't identified, and I do believe that's true, but I believe these drugs act synergistically. So all of these studies done, they just look at one drug at a time. When you put the drugs together, I think you get markedly increased synergistic interaction. That's why I try to get people, I mean, if you take care of dialysis patients, that's a miserable life. So I can't tell you how many times, I have people come in and say, Dr. DeFranzo, okay, this is my last day. I'm not coming back dialysis anymore. They always come back, but the fact their life is miserable. So if I can prolong the time that they get on dialysis by 5-10 years, that's enormous. So I'm very aggressive in trying to get them in all 4 drugs, if they can afford it. That's a big issue. Finerenone is very expensive.
So with the 4 drugs in the non-diabetic kidney, GLP has been replaced with the endothelin receptor antagonist.
Yes. So in the non-diabetic kidney, we don't know about GLP-1.
So that's endothelin receptor antagonist they have given.
Yeah.
And the advantage of SGLT2 is that you don't require a diuretic because for the full detention, which will happen with endothelin receptor antagonist.
Yeah.
So that's the advantage.
A good point about diuretics. I think it's very difficult to control hypertension unless you're on a diuretic. So although I took you through the 4 pillars, most of these people are going to be hypertensive, and I think you're going to need a diuretic as well to control the blood pressure in those people.
And 2 questions again. One is the specificity of EMPA in normal albuminuric CKD. Normal albuminuric CKD, normal albumin.
Yeah.
And the positioning of finerenone in these type of patients, where do they stand?
Okay.
And the second part.
Let me take the first question first. So what he's asking is what about normal albuminuric CKD? So if you look at diabetic patients, about 20% of them have a marked reduction in GFR, but really no albuminuria. In the sub-analyses that have been done with the SGLT2 inhibitors, those people benefit as well as the people who are proteinuric. So I would not treat them any different. And that is why it's critical in all of your diabetic patients, at least annually, you need to have a urine albumin to creatinine ratio and an eGFR. Many physicians only get the eGFR from the creatinine and don't get the urine albumin to creatinine ratio, so they miss a lot of people. On the other hand, there are people who have no albumin in the urine, have a low GFR. Those people need to be treated as well. Second question.
Patients receiving all the 3, receiving RAS inhibitors, finerenone, SGLT2 inhibitors, along with that GLP-1, still having proteinuria. What will be your further?
Pray. I mean, if I had another therapy, I would add it. But you know, we don't have another therapy. So these are the 4 drugs that are approved. So there are now studies that are ongoing uh, with the aldosterone antagonists.
Okay.
These drugs are very, very powerful, and I personally believe that aldosterone has direct renal toxic effects. And so blocking aldosterone, when you're an ACE and an ARB, at least half of the people escape from the benefit of the ACE and the ARB within 1 year. So I think Baxdrostat, just approved by AstraZeneca and a whole bunch of them to come. There are also endothelial antagonists that are being developed. So I do believe that we will see other drugs. We don't have them yet, but when they come, I would be adding them. Again, these drugs, newer drugs, are going to be expensive.
And your take on baricitinib on that?
Same thing.
Baricitinib, it's available. So any idea about that used drug?
I don't know that it's going to have benefit above and beyond the big 4 that we talked about.
Okay. Last question. I think this is the last one.
Sir, few patients on SGLT2, they come on complaining that they are losing faster weight. They said that the pant we used to wear now becomes loose to them. So should that be done anything more apart from ruling out the other causes? We have excluded the other causes of excessive weight loss. So should we stop SGLT2 inhibitor for time, sometimes reevaluate then, or should we continue with?
Yeah, the SGLT2 inhibitor is not, as I said, you lose about 3% body weight. So that's not going to be a problem about losing too much weight. Where the issue comes up is more with the newer GLP-1s. So Ozempic and tirzepatide and the new one to come, retatrutide, you can get up to 20 to 25% body weight loss. So there is some concern is should you back off on the dose, not discontinue.
Okay.
You need to understand that obesity is food addiction. It's no different from drug addiction, alcohol addiction. You stop the drug, the people will regain all of the weight. So if they now come down to it, let's say their BMI is now about to 25, I would consider reducing the dose, not stopping the drug.
Okay. The last question from Rajan.
They have lost weight more than 10 kg. Who is on SGLT2 inhibitor? They lost weight more than 10 kg. There are patients, less number of patients.
Yeah.
They lost more than 10 kg.
If they lost more than 10 kilos and they were still above a BMI of 25, it wouldn't bother me. As I said, once you get down to normal body weight, I don't think you want to be having people go below normal body weight. So I would say the same thing I said for GLP-1 for SGLT2. I haven't found that to be an issue in my practice, though. I wish that people put on an SGLT2 would get their body weight to BMI. Come to San Antonio. The average BMI in my clinic is between 35 and 40. So I'm not too worried about people getting a BMI down less than 25. But if you got to 25, I would back off on the dose.
So the last question of tonight.
Prefer time for giving whether it is morning or evening. Why I am asking, because in India, some people have come with combination with the ARNI with the DAPA, 5 milligram morning and 5 milligram evening. So what is your take on this?
Giving SGLT2 inhibitors at night, should we?
Doesn't make any difference. It works 24 hours. And if they want to take it at night, you know, when you start the drug, you're going to urinate more. So if you give it to them at night, they're going to get up and pee at night. They won't like you. So I prefer to start it in the morning, but it doesn't make any difference when you start it. It's going to work.
It's what. But in India, few company has come with the combination of ARNI plus DAPA. ARNI 50 milligram and DAPA 5 milligram.
That's
and
okay.
They are advocating BD dose.
They're advocating splitting the dose?
BD dose.
No, no reason.
Just for the sake of adherence, they have bifurcated the dose into two. Instead of giving the 10 milligram once a day, they have just combined the 5 milligram of DAPA with sacubitril/valsartan. And then they are advocating that.
I think you should try to get people on the maximum doses of the drugs, and you only have to take them once a day. You don't have to split doses and be taking some in the morning, some in. I don't know why they would say that.
So thank you, sir, and a standing ovation to sir. And as I said, we are blessed to have sir over here.
All right, thank you. I can disconnect myself here.
I think a big round of applause for Professor D. Franzo and Dr. Santosh Kumar Singh and to the panelists as well. And thanks to all of you for making this a great summit. Thank you.
That's $5 per picture. Okay. Okay, your next plan is
I request Dr. A.K. Das, Dr. Ranjan Kumar, Dr. E. Haq, Dr. Chandan Kumar, and Dr. Prabhu Nandan Prasad. Kindly, okay. Sir, just a second. You would like to felicitate.
Occasion possible for us.
Thank you. Thank you so much, sir. It's a felicitation.
चलो लास्ट तक है ना शुरू से चंदन कुमार
Okay? Okay.